Hello class, and welcome to a lecture on the kidneys and the urinary tract. So we'll talk about ureters, bladder, urethra a little bit. And some important pathologies here, pathophysiologies. When you look at what's going to kill you, we talked about heart issues, lung issues are big, then liver and kidneys. There's a lot of people with chronic kidney disease. And so we'll get to all the subtleties there. It's just an amazing, delicate organ. We have two. Luckily, we have a backup. You only need one. But you have about 1 million nephrons in a kidney, and they're very, very delicate. That filtration membrane has to be just right. So it's a lot of things that can go wrong. And when they go right, you just take them for granted. You know, you pee, urine comes out, you have proper water levels, electrolytes, everything like that. And if you think about the amazing function of just your water equilibrium, I mean, you could drink gallons of water in a day and you pee out gallons. Or you can say, I'm just going to drink this 1 glass of water today. You just pee out a little bit. And so if your kidneys didn't work, you'd either blow up or you'd shrivel like a raisin. So you have this amazing ability. That's just water. And then they take care of all of your magnesium, calcium, phosphate, sodium, your pH. I mean, your kidneys are taking care of your homeostasis so that your blood chemistry and your cell chemistry is just right. So they're amazing organs, but things can go wrong. And that's what we're going to talk about. All right, so let's get to it. So you have two kidneys, and they are, in fact, retroperitoneal, meaning that they're stuck to your back wall beneath that parietal peritoneum. And they're surrounded by a big, thick layer of fat. They're all in this fat. Above are your adrenal glands, and they're not directly connected, but they're right above them. And they're stuck back there. There's a little movement. You don't want too much movement. There's a little bit of movement as you jog. They can go up and down, less than 1 inch is fine. And then coming off of them will be your ureters. You got a right and left ureter. Those are also stuck behind the peritoneum. And they'll enter the bladder at an angle. And coming in at an angle through that bladder allows it to act as a valve. So that as the bladder fills and pushes out, those ureters get compressed the more pressure there is, and it tries to prevent backflow of urine going back up into those kidneys. Kidneys get so much blood from the renal arteries. They get like 20-25% of your blood volume. Even though the kidneys are about 1% of your body weight, they get all that blood. So it's that blood pressure going to these kidneys that's going to filter that blood. And then after the bladder, the urine will go out the urethra. It's a little more complicated in men because it's got to go through the prostate and through the penis and such longer. And so it shares in men the reproductive and urinary chores. In women, it's just the urethra is just for urine. All right, kidney anatomy. We're not going to go through all of it, but you all remember the cortex is along the outside, and that holds all the glomeruli. And then the medulla, or the middle, it's made up of these pyramids. And then the renal pelvis here is where all the urine is collected through minor and then major calyces into this pelvis, which is going to leave as the muscular ureter. And so urine will drip out of the tips of these pyramids, the little papilla, and collect in the minor calyces that'll come together in a major calyx into the pelvis. And once the urine drips out of the pyramids, there's no longer, you don't adjust it or anything like that. In the gallbladder, we made bile, and then the gallbladder sucked out the water and concentrated it. Here, whatever comes out of the pyramids, it's urine, and that's it. You just travel it down. The bladder doesn't concentrate it, it just holds it. Beautiful. And in anatomical terms, we talk about the upper and the lower urinary tract. Upper, we'll call it the kidneys and the ureter. And then below will be the bladder and urethra. So we talk about, in this case, urinary tract infections. Lower, if you can keep it to lower, but that bacteria can get up into an upper urinary tract infection, which is more serious. So kidneys, their functions, again, they get rid of nitrogenous wastes. Because you break down proteins, they're made up of amino acids, amino the nitrogen, And so you'll make ammonia, which is toxic. And your liver will take a couple of those and make urea, which is soluble in water and less toxic. And then your kidneys can filter it out and get rid of it. And you break down nucleic acids, DNA, RNA. The N is nitrogen. So those nitrogens also your kidney will get rid of it. You can make uric acid, which is a bigger molecule. It's not quite as soluble, but it's another waste product that we make. And, you take drugs, including antibiotics and things like that, and your body recognizes them as not being normal, and your kidneys will get rid of them. So whenever you're giving drugs for a therapeutic effect, you need to know how the kidneys are getting rid of it, at what rate, so you can keep it at a good level in your body. And then water and salts, that's what your kidneys are about. Acid base. Most of your actions in your body produce acids, and so you can get rid of hydrogen ions. So urine is usually acidic. It can be alkaline down to 4 or something like that. And then I'll just review quickly. If you have kidney issues, you can have some wild blood pressure issues too. Because in the kidney tubules, remember, they sense, in each nephron, they sense your blood pressure. And when it gets too low, or you have low sodium levels in the fluid, they release renin. And renin's going to make angiotensin 2 eventually. And that's going to do everything to raise your blood pressure. So it's about blood pressure. And then hormones we'll talk about. It makes EPOs made there and some others. So this is looking at microscopically. This is the glomerulus. It's a ball of capillaries, just delicate. And the rest of it is all just tubes, proximal, distal tubes all over the place. And so they're going to reclaim the fluids and all the good stuff and get rid of the bad stuff. Mesangium are going to be the cells that are in the middle of the tuft of capillaries. They got some important functions. So the nephron, basic unit, got about 1 million per kidney, and it involves glomerulus, which is the blood, and then a tube system, right? You've got this Bowman's capsule or nephron capsule, proximal convoluted tube, the loop, nephron loop or loop of Henle, distal convoluted tube, and then collecting ducts. Yeah. And then the interstitium, we're talking about diseases of the glomerulus itself. You see, that's where a lot of things happen in that delicate filtration membrane, but also interstitial diseases. And you have problems with tubal problems or the interstitial, the cells around it. So again, the afferent arteriole brings the blood in. The efferent arteriole takes the blood out. It's smaller. And so it is the blood pressure. Just like if you have some filter paper, and you put some water in there, it's going to be pushed down by gravity through this porous filter paper. Here you have this porous membrane in the glomerulus, and then is going to be your blood pressure, your BP, that's going to be pushing the fluid, and only the small stuff that can get through those little pores will get through. So glucose and sodium and water, all these things go right through, but red blood cells, white blood cells, platelets, big proteins, they don't go through this membrane. They're too big normally. And all this filtrate is captured in this capsule that begins its journey down these tubes, where the tubes can reabsorb the good stuff, the glucose, the vitamins, everything you want, and get rid of some bad stuff. You can pump it out. All right. And here, this is this filtration membrane. We looked at the respiratory membrane in the lungs. Remember that? Super thin endothelium of the capillary basement membrane. And then the alveolar, type 1 alveolar cells, super thin, right? Here, you're going to have the endothelium of the capillary, but in this case, it's really holy and leaky, called fenestrated. The holes are fenestra. So it's really leaky there. And then the basement membrane, acellular basement membrane, every epithelial tissue has one. And then on the outside, there's a epithelial cell called a podocyte, like podiatrist, it means a foot cell. And podocytes come out and they have little extensions, like an octopus. And they will, and then another one will come in. And so by the end of it, you've got all these little podocyte, little fingers coming out, or feet, I guess. And those little filtration slits are going to be small enough to work as an additional filter. There's the holes in the capillary. Then the material has to get through this basement membrane, and then they've got to get through these little slits of these podocytes. So beautiful view, electron micrograph here. You can see the gaps, and then the gaps between the extensions of the podocytes. And here I'll show you the pathology. So here's normal. The A over here is normal. Beautiful. You guys see that? You see the holy or fenestrated capillary endothelium. You see the basement membrane, and you guys see the podocytes from different podocytes, the little interdigitating fingers like that. So that's a beautiful, healthy looking membrane. And then over here, you can see, whoa, a big difference there. That basement membrane is way too big. The podocytes have now just kind of coalesced. They don't have that nice, cool filtering thing. And I just love this. The beauty of the podocytes on the glomerulus, just unreal. Look at that, those little fingers interdigitating. You guys appreciate it, good. All right, and so how this works, of course, is that what comes out of the blood, it's like 180 liters, like a 55-gallon drum full of fluid. You clearly can't pee all that out in a day, right? You only pee out like 1.5 liters. So most of that fluid gets reabsorbed, right? And so you reabsorb 98, 99% of the water comes back, and the sodium, everything you want to keep. And then you secrete substances. Usually water is a passive process. Some of these are active processes, like glucose, you have to actively pump it back. So it's a combination of active processes using energy and passive processes that you take that 55-gallon drum worth of fluid that came out of the blood, and you distill it down to just how much you pee out in a day, which is a couple liters at most. Yeah. And how you do this, just don't, again, I can't review all of kidney physiology, but you guys know it gets saltier and saltier the deeper you go into that medulla, right, in the pyramid. And so that gives the fluid coming down the ability that if you have ADH, you open up these pores, these aquapores, and you're allowed to suck water back up if you are dehydrated and you're being stingy with your water, or without ADH, that tube remains closed and you be able to pee out a lot of water. All right, so indeed. So ADH, also called vasopressin, comes from your posterior pituitary gland, and it affects the tubes on your kidneys, how porous they are to water. Okay? And then again, your liver makes angiotensinogen, this big protein. It's always circulating angiotensinogen. But when your blood pressure drops, tubes in your kidneys and the nephron release renin. It's a hormone, and that's or an enzyme. It's going to convert angiotensinogen into angiotensin 1. Does nothing. But then angiotensin converting enzymes, ACE, are going to convert to angiotensin 2. And 2 is powerful. It is going to make your blood pressure go up. It's going to cause your vessels to constrict. Your heart's going to work harder. You're going to secrete ADH and aldosterone from your adrenal gland. It's going to make your kidneys keep the salt, that's keeping the water, so it keeps your blood volume up to raise your blood pressure. It's going to make you thirsty. So yeah, angiotensin 2 does everything to keep your blood pressure up. And so people with chronically high blood pressure will take ACE inhibitors. You don't make angiotensin 2, you don't have those effects of the high blood pressure. All right, the hormones, EPO. So people with chronic kidney disease, what would be one of their symptoms? Well, many things, blood pressure problems, but anemia, because they're not making the EPO, because the cells in the kidney are being destroyed that make that, right? So you'll see that. Calcitriol, vitamin D is a complex vitamin hormone, but kidneys are involved with it, and this vitamin D causes your intestines to make more transporters for calcium, so you absorb more out of your diet. And then the renin. When renin's released, it's going to increase your blood pressure. All right, I couldn't possibly review all of kidney physiology. In A&P, that was a tough exam. There's a lot going on. What's going in and out of kidney tubules, but now we're going to get to some of the issues. So we'll talk about UTIs. We'll talk about glomerular problems. We'll talk about some developmental problems. Yeah. Well, here, the overview of everything we're talking about today: UTIs, urinary tract infections, and second only to upper respiratory infections in humans. And women get the short end of the stick here, mainly because of their anatomy. The urethra in females is much shorter. It's next to the anus too, so much easier for bacteria to gain entry into the bladder. Men have a longer urethra, and the whole length of the urethra, there's mucus glands along the way to kind of prevent the outside world, because urine is supposed to be sterile, but it's a good medium. Bacteria can grow in if they get introduced, and you got to fight that off. And if you get a bladder infection, cystitis, the issue is it can travel up to your kidneys and become kidney infections called pyelonephritis. So if you have a kidney infection, that can, besides the pain, it can actually cause damage to your kidneys, long-term damage too. Yep. We'll talk about calculi or stones, and I'll talk about how they form. And apparently one of the most painful things is trying to pass a kidney stone, but they can be asymptomatic, but then they can lodge into your urethra, the ureter, and cause issues. Yeah, if you hear end-stage renal disease, and you see people in the hospital, they have chronic kidney disease, it gets to end-stage renal disease, and kidneys are just not functioning. So all the functions they're supposed to do are not happening. Nitrogen, urea builds up in your blood, your blood pressure's out of whack. Usually, you have hypertension and edema. All these bad things happen if your kidneys aren't working. And at the end of it, if your kidneys fail, you need either dialysis, we'll talk about, or a transplant, a new kidney. And we'll talk about a lot of diseases, some infectious, a lot of them are just degenerative, but the big issues with your kidneys with people is high blood pressure and diabetes. Those things are hard. Remember the delicate arteries, diabetes, high glucose levels, they affect the small delicate arteries, like in your eye, in your extremities, and in your kidney. They're really rough on it. Hypertension too, that high blood pressure is going to cause those delicate arteries to get thicker and block off blood flow, and so, yeah. And then malignancies. We'll talk about some cancers, bladder cancer and kidney cancer. All right, let's get to it. So first of all, it's hard to really palpate the kidneys and bladder. They're really deep inside you. But some of the things, some of the symptoms definitely are issues with urination. And so increased frequency, maybe you try to pee, you can't pee very much. Dysuria, like dysphagia with swallowing, is a painful urination. Nocturia is you got to wake up in the night to pee all the time. It's a sense of urgency that you've got to go right now. If your urine, you can do urinalysis. We do that in A&P. If it's cloudy, talking about pus, usually some kind of infection. Hematuria is blood in your urine. That'll be reddish. Anuria, you stop urinating. So in the hospital, yeah, they check if you've got a catheter. If you're not urinating, it's an issue, right? They got to fix it right away. And oliguria means just a small amount of urine. Anuria means you're not peeing at all. What's going to be some of the signs and symptoms you're going to see? Well, when you have an issue with especially the kidneys, it's often the flank region or the upper back, kind of like above where the kidneys are. You can have fevers if there is a kidney infection. You're going to be fighting it off. There'll be a fever, and edema too. You will see that if there's some of your kidney problems allow proteins to leak out, and then you're going to have less proteins in your blood. Then less osmosis, going to be less fluid's going to come back. And blood pressure issues. Remember, the kidney is important in fluid retention, and also renin, the hormone too, could be that. But if you retain fluids, you're going to have high blood pressure if your kidneys aren't getting rid of water. All right. Physical examination is a little tougher. The kidneys are protected by your floating ribs and a bunch of fat. You can palpate them sometimes and feel maybe a lump. You can do a tap on it, and if you have pyelonephritis, that'd be painful. You kind of hit some on the kidneys there. But the urine, I mean, you can get a urine sample and tell a lot about kidney function there. So urine, easier to get in blood. You pee in a cup. You want to get a midstream sample. You guys remember that? The first amount of urine that comes out is going to get all the bacteria, everything in your urethra, right? You want to get rid of that, and so you get a little cleaner sample. But you look at the color of it. It's normally has to do with hydration. If you're really hydrated, it'll be watery, and if you're dehydrated, it'll be darker and darker and darker. The cloudiness usually is because of pus white blood cells from some kind of infection. And of course, hematuria is blood. If you see blood in your urine, yeah, get that checked out. It could be just a bladder infection, but it could be cancer that's bleeding, a bladder cancer, kidney cancer. And so you want to check out what's causing that blood. Or it could be a problem in your kidneys where, remember, red blood cells are not supposed to get through the filtration membrane, but if the filtration membrane's busted, you'll have blood coming all the way from your kidneys. Yeah. And sometimes if you eat a lot of beets, you can have bright colored urine. And there's drugs that make your urine neon yellow or bright orange, and it can be very disturbing. There's a disease where blue diaper syndrome, where some babies, it's like blue, bright blue urine because they have a hereditary issue getting breaking down amino acid. And odor-wise, y'all know this. If you haven't had asparagus before, well, you got to try it. It's really good. But your pee smells pretty bad for a while. And then it's from my lab. We do a spin it down and do a sediment analysis, so you can see what's in there. And what's in your urine? If you see red blood cells, hematuria, right? If you can find white blood cells, means probably infection. You can see bacteria or fungi, looking at infections. And then crystals, all kinds of different crystals grow in different pHs. And if you have a lot of crystals, it means you could be, in danger of a kidney stone, right? Definitely. What else? And then casts. Casts and all the delicate tubes in the kidney, the proximal tube, collecting ducts, you can have a precipitate form in the tubes and then it comes off. And they can be made from red blood cells or made from white blood cells or just be casts from just precipitate in the fluid. That's what those are. So urinalysis, very important tool. It's very easy when we have these test strips. You can get a sample of urine, do the test strip for a minute or so, and then check these colors, and you can tell a lot. If you have a lot of protein in your urine, first of all, it'll be frothy. When you see the frothiness to a urine, it's because of protein. Glucose should be none. Your body should take back most of that, unless you eat a hell of a lot of sugar, or you're diabetic uncontrolled, you'll have sugar in there. Yep. And then ketones are from breaking down fatty acids. It means you're starving yourself, or could be diabetic and have ketoacidosis, making too many ketones because you can't break down carbs because your cells don't bring them in because of the insulin problem, but then you break down fatty acids and you make ketones. Yeah. And then leukocytes or leukocyte esterase means an infection. Yeah, definitely. And you can look at specific gravity is how concentrated it is. So you look at your hydration. And pH, it can be from acidic to alkaline, usually acidic. Yeah, so all these things give you clues to what's going on inside you. Blood panel, urine panel, all these things will point you in a direction. Now, when you take a look at, you do a chemical panel, look at the blood, if you see creatinine or urea, high levels of it, it means, damn, was my kidney supposed to get rid of that? Yes, it was. You're always going to have a certain level. You can see, let's see, urea reference 10 to 32, creatinine 0.6 to 1.4. So there's always some you make it. When you break down muscle, remember creatine phosphate in the muscle, this creatinine, you need to get rid of it. And so there's always a background amount of creatinine because your muscles are always producing it. And your kidneys get rid of it at a certain rate. But if the kidneys are failing, those things build up. They build up in your blood. So this patient has a creatinine of 3. It should be no more than 1.4. And I'm looking at urea's 86. Oh, damn. Should be 10 to 32. Yeah. So those things are red flags, and there's other issues in red there. Yep. So these things build up, blood, urea, nitrogen, that kidneys should take care of. It means your kidneys are not doing their job. You got to check on that. All right, we can use a cystoscope. Cystoscope. It's easier in females. You can see a male, you've got to navigate the penis as well. But you can put that in, there's got a lights and a camera, and you can even have little instruments in there to do some things. So that's one way of looking directly inside the bladder. Yeah, get a biopsy if necessary. And a cystogram, they can inject opaque dye, take an x-ray and see where the fluid is going. And intravenous pyelogram, they can take a look by putting opaque dye and see, is there a constriction in the ureter? You can see if there's stones because they'll pop out because there's no fluid right there. But it's kind of being replaced with awesome CT scans where you can get a three-dimensional reconstruction and take a look at all this. I got another picture of it. Yeah, look at this. Oh, so cool. You can see that little cyst right there. And you can see like here's a constriction. It kind of looks dilated proximal to that. So they want to, there's an issue here, there's an issue here, and they can go in and try to fix that. On this side, there's no dye here. Yeah, so with these imaging techniques, it tells them what the issue is, at least where to start looking. All right, so you have a kidney issue. They want to figure out what it is. They may need to do a biopsy. So to do a kidney biopsy, they guide it with ultrasound, they put the needle in, and you could pull out a section of tissue, get it stained, and examine it. Take a look. It's really nice when people have a chronic disease, they can take sequentially, keep taking biopsies to see how fast is it progressing. They can see, is it a glomerular problem, an interstitial problem? They can look at it microscopically. All right. So all these tests, obviously a urine test is good. They can use cystoscopes and other x-ray techniques to find out what's going on. All right. So Potter syndrome is our first genetic developmental disease. And the kidneys, there could be a lot of abnormalities. There's different shapes in kidneys and issues. There's a lot of developmental problems with them. So just put that out there. But Potter syndrome is one that the kidneys are not working right, and they don't make enough, they make the amniotic fluid actually. So you get this syndrome where the lungs aren't prepared, the face has a particular look to it, and so very sad. They normally don't even survive till birth. You can look up, there's a couple cases where they actually grew up, but normally this is not very suitable for life because they have all kinds of abnormalities involved with this because kidneys are malfunctioning, they're not making enough fluid. All right, you can have, this is a horseshoe kidney. It just fused in the bottom. It's usually, they find it in autopsy, like, that's kind of cool. You don't see that very often, but it usually won't have any effect. Agenesis means you don't make a kidney, but you're okay if you have one kidney. Yeah, so one kidney, once it's okay, you can live with that, obviously. Now, this is interesting. If hypoplasia or small kidneys like this, and so there's not many nephrons in there. It's supposed to be 1 million, there's like a fraction of that. And you think to yourself, well, I got the other kidney, it's fine. But it turns out when you have this situation, the little kidney kind of freaks out because it's not getting enough blood. Everything is kind of screwed up. So it sends out these signals that we got to increase blood pressure, increase blood pressure. Blood pressure is fine, but the kidney is screwed up, so it thinks it needs more. And so that has a systemic effect where it increases your blood pressure. So they'll often go in this case, maybe, childhood, you're going to see this. And as you go on, they're like, okay, this is not worth it. Let's just get rid of the smaller kidney. And then things go back to normal. You only have one kidney, so it's always a risk with one kidney, but people have lived their whole lives with one kidney. Yeah. All right, renal dysplasia. That's when you're going to have the tissue is not put together correctly. All right, and so you see some weird kidneys. Yeah, the glomeruli, tubules not put together. You can have weird mesenchyme can be made out of other kinds of tissues. So renal dysplasia means your kidney is not made right. And you can have one that's perfectly normal, and then you'll be fine. So yes, often see cysts everywhere. Yeah. If the other kidney is fine, you'll be fine. All right, polycystic kidney disease, really interesting. Obviously means polycyst, you have many cysts. And when you look at a cadaver kidney, you're always gonna see some cysts. Not always, usually gonna see some cysts. Little pocketings, a tubule. After 80 years, it balloons out, gets some fluid in it, and that's fine. But this polycystic kidney disease, you see there's two kinds, is when the whole kidney is taken over tissue by cysts, making it huge. Look at this pair of kidneys. See, that person's right kidney is just humongous and useless because it's been taken over by these fluid-filled cysts. So yeah, two types we'll talk about. Look at the size of these. It's got to take over your whole abdominal cavity. So the first one is they're not sex-linked. So the recessive polycystic kidney disease, that's going to come out right away. You're going to see there's a problem. So there's a big gene here that's involved in tubes in the kidney, making the tubes correctly, and also the bile ducts in the liver too. So yeah, so you often see problems with the liver and the kidney together. And yeah, this is an issue you'll see even prenatally in ultrasound. You can see cysts forming in the kidney at that stage. So it happens early, and they've got to do something about it. And it can cause that Potter syndrome too. But this one, the autosomal dominant is much more common. And this comes about as you get older. So you're an adult, and all of a sudden you've got this high blood pressure. That's weird. And combined with high blood nitrogen, and like your kidneys, your blood work says your kidneys are failing. And then they take a look at ultrasound or CT scan, like, oh, you've got polycystic kidney disease. And it is genetic. I brought a speaker in. I gave a whole talk on this polycystic kidney disease. So I know a lot about it. And so you can do genetic screening to see if you're likely to have it. Again, that doesn't stop it, but you can have that so that you can monitor more closely and not have it be a surprise. But your kidney is taken over by cysts, and depending if you have a very rapidly evolving one, you're going to need dialysis and a kidney transplant. Yeah. Yeah. All right. Another thing that can happen is you can have reflux of urine up your bladder to your kidney. So vesico, it means bladder, up your ureter. So it goes from your bladder up your ureter, reflux. And normally you don't want this to happen. You want urine to go one direction. It fills the bladder, you pee it out, fills up again, right? Yeah. And so what can happen though, if you have this back pressure, you have this hydronephrosis where water in your kidney, you can see here this progression. And it's just this constant pressure is going to cause the normal kidney tissue to just regress and regress and regress. So it can eventually destroy your kidney. In the CT scan, you can see the pressure just has ballooned that ureter as it's leaving. So in your bladder, you want the ureters to enter at an angle through the muscle of the bladder. And in boys more often, that doesn't happen sometimes. It's more direct. And then when the pressure in the bladder increases, what happens? That urine goes back up. Causes problem. Yep. So sometimes they wait and see if you can get through that. As you mature and the ureter gets longer, you might not need it to have surgery. But if it's an obvious problem that's going to destroy your kidney, they can do surgery to do some corrections. But you're looking at a kidney with these huge spaces in there. All right, urinary tract infection. Like I say, very common, more often in women than men. But you have contamination of bacteria. It's usually E. coli that comes in from the outside world, and it starts living in your bladder and causes symptoms. Yeah, usually you can do look at urine. You'll see it's cloudy. It has bacteria in it. It has white blood cells in it, and you know that. So yeah, dysuria, urgency to go, all these kind of something doesn't feel right in your bladder for sure. And can be treated well with antibiotics. Sometimes people have recurrent infections, and so the bacteria lives, kind of hides in the bladder. You can't completely get rid of it. You got a lot of these cases, but normally we got a lot of antibiotics that can kill these things. So what are some of your risk factors? Well, being female, because the anatomy, and about half women in their lives will have a UTI. Yeah, so sexual activity is one thing. Having any obstruction, you have stagnant urine, bacteria can grow in it. If you've got a chronic illness, it's going to lower your immunity. You can't fight off bacteria as well, and they can take a hold in there. Yeah, and then some of that are caused by healthcare. If you have catheters, putting in can introduce bacteria in there. I didn't mention it, but also when you intubate someone in the hospital, bacteria, you often give an antibiotic just because that tube going down there can introduce bacteria, even though you try to be as sterile as possible. And some other infection in your body can travel through the blood and make it into your kidneys. Yeah, and if this bladder infection reaches your kidneys, pyelonephritis, infection in your kidneys. And the reason it's more serious than the bladder infection is that unchecked and chronically, it can cause damage to your kidneys. Once they're going to be inflamed, and then you can have turning into scar tissue and less active kidney tissue. Symptoms, that flank pain, and since it's an infection, fever, high white blood cell count, more neutrophils in your blood would be symptoms of this. And then you can percuss it and it could feel some pain. Diagnosis-wise, yeah. I mean, they can do a biopsy, but that's not necessary. If they see all kinds of white blood cells and they have you have pain in the kidney region, that's pretty good indication you've got a kidney infection, and then we give you some antibiotics. And if there's any factors that contributed to this kidney infection, they can try to take care of that. Looking at the microbiology, you can see E. coli, big time, and then some others, so staph, candida, so fungus can cause some of these. But they do a culture of the urine, they figure out what it is, and then the antibiotic choice can be more tailored, although you're pretty good guess with E. coli. All right, so chronic kidney infections. They can damage the kidney. And you look at this histological section, this thyroidization, nothing to do with thyroid hormones, but it looks like a thyroid. Remember the histology of the thyroid gland? And look, had all those follicles filled to that thyroglobulin. So it kind of looks like that because you degenerated the nice kidney tissue, the tubes, the glomerulus all atrophy, the tubes fill up with fluid, and they kind of look like a thyroid there. You see a bunch of neutrophils in the interstitial tissue fighting infection. So a biopsy looking at chronic pyelonephritis sees damaged kidney that is just under attack by bacteria in your body, has mounted a response, and it has caused damage. All right, kidney stones. Never gotten it, but I talked to someone that just says, oh man, it's horrible pain to try to pass that kidney stone. These are things, crystals form. You guys know your chemistry. You get a concentrated solution, and any kind of little seed that begins a crystal can form. And so that's the issue. And then we talked about in gallstones, right? Usually cholesterol or bilirubin, things there. Here we're talking about, it's usually made out of some calcium oxalate or calcium phosphate crystals, but they can be made of some other stuff too. The most important factor is that you want to, when you concentrate, so if you drink a lot of water, you have dilute urine, that's cool. But if you're constantly dehydrated and have lots of calcium, maybe you've got a parathyroid hormone tumor, you have way too much calcium, really be predisposed because you got so much dissolved substances, it's going to make these concretions. 1 million Americans, yeah, a lot of you in your lifetime will have kidney stones. And it seems to be increasing. Something to do with our diet, our lifestyle. Definitely, yeah. I'll just show you some pictures. Isn't that beautiful? Look at how sharp those crystals are. Oh yeah, that's gotta hurt, passing that one. Yeah, cool, calcium oxalate. And here's a uric acid one, kind of a smooth kind of look to it. If you have gout, of course, that you make too much, that's too much uric acid, and it builds up at your big toe and the joints and things. So gout is too much uric acid, so it can contribute to this. If you don't pee very much, you're not very hydrated, you're more likely to have concentrated urine. Yep. I mentioned parathyroid gland, too much calcium is going to be excreted, definitely. And some bacterial infections, some things predisposing you to these. This is a staghorn stone because it fills in the calyces in the bladder. It's often, they call it a struvite. It's got magnesium as part of it. But these things, you're not going to pass that, right? You got to go get rid of that. So diagnosis, if you have kidney stones, there's the pain, you go in and they can do x-rays, but the better way to go is ultrasound because it's going to see all the stones. X-rays will just show you the ones that are harder calcium ones. Yep. Yeah, worst pain ever experienced. That's a good clue. So treatment. Take your pain pills, drink lots of water. I mean, they hope that they pass. I mean, that's what you usually do. You know, if it's just not passing, then they'll say, okay, I'll take a look. Sometimes they can sneak a catheter up and grab it. They might do surgery. More likely they'll do this lithotripsy, where they'll hit it with sound waves and they'll break it into little pieces. So that's a common procedure done, lithotripsy. All right, so we're done with stones. Now we're just going to talk about issues of the glomerulus and then cancer. So what we have left here. So glomerular diseases, that's where you have an issue with this delicate membrane. I set us up for this in the intro talk, giving you the reviewing that anatomy. But if there's issues here, what it's normally the issue is there's immune cells that either attack that basement membrane or antibodies glom it up and causes a reaction so that your glomerulus becomes really leaky. And so you start peeing protein or peeing blood that the healthy membrane would have stopped. So that I'm giving you the punchline now. But you're going to see proteinuria, protein in your urine. And when you guys do urinalysis, some protein is normal if you work out really hard, or there's always like some background protein, that's okay, but this is a lot of protein. You shouldn't lose it through your pee because it's valuable. You don't want to pee it out. Hematuria, you got blood in your urine. Could be an issue further downstream, but it could be coming right from the glomerulus. Edema. So if you're losing all this protein out of your blood has less protein in it. Your liver will try to make more, but you're going to be swollen because fluid's going to leak out because you've lost this protein. Yeah, and then you've got less protein in your blood, albumin mostly because you got rid of it, and then increases in I guess decrease in kidney function. You've got increasing levels of blood. All right, so to finish this up, I just put this line here just to let you know. The book, I'm not going to just follow it just word for word here. Like I'll give you kind of big picture what you need to know here, and the book mentions a few other details that I'm not going to get into. So feel free, read that, get it all that you'd like. For my lecture here, I'm going to just set it up for you so you have the basic outline here. You may not think it's basic, it's kind of complex, but do my best here. And so kidney diseases, first of all, they can be the kidney itself, or it can be a secondary disease. You can see hypertension, diabetes that causes these issues. All right, so there's two big groups here. So follow me here. There's nephrotic and nephritic. These two syndromes means these are issues that happen, and diseases can be put into one of these two. So it's not a disease here, but it's two syndromes that are caused by these diseases. So nephrotic, what you're going to find is you're going to find protein in your urine. So the membrane, here's a healthy glomerulus where you can see the little dots of the proteins. You see white bloods, red blood cells. Now, if this membrane is damaged, these proteins will get loose. And this picture here shows it's so damaged you have blood cells and protein leaving. But with nephrotic, you don't see blood in the urine, but you see lots of proteins. If you lose proteins, the patient's going to show edema, swelling. Okay. And then nephritic, you see blood and protein. So the damage to the membrane is more severe. It lets freaking blood cells out. They're really huge, right? And that's this usually nephritic is going to be inflammation to the kidney membrane. And so it's going to damage it. Yep. And indeed, blood casts coming down. Yes. Another view looking at nephrotic. Look at that edema. The urine has a lot of protein in it. You're going to have low albumins in the blood itself. Yep. And here, nephritic, you'd have blood in the urine, but less urine, that kind of cola colored. So it's going to be dark because of the hemoglobin is making it that color. Yeah. And you'll also see here when you get rid of albumin, your liver makes a lot of lipids too. So you often see hyperlipidemia. You see a lot of high fat levels, low protein levels. You see that in your blood, it's like, oh, okay, they've got a nephrotic syndrome. They are losing the protein. Your body makes a lot of lipids. The liver does, as a byproduct, trying to react to that. All right, so kind of set this up. You can, YouTube some more videos. You want to get some more detail on this. All right, so these glomerular diseases, a lot of it are immune responses. So recognize the antibodies? Yeah, immunoglobulins or antibodies. And sometimes these complexes form because of an infection, and then this antibody will stick to the antigen, and then they'll all stick together. They make it to the kidney through the blood vessels, and they'll get stuck in that basement membrane. And sometimes it causes an inflammation in the basement membrane. Or sometimes there'll be reactions, cross reactions so that the antibodies start attacking the glomerulus, parts of the glomerulus, and so causing them to be infected, and they get inflamed. They open up and they allow proteins and blood to get through it because you've damaged this. All right. So you can have antibodies that act against your own freaking basement membrane, right? It's autoimmune. It's attacking itself. And often gets confused because the antibody was made for strep, and then it's kind of similar to this basement membrane. It's like, I'll attack that. Not good. All right. So this post-infectious glomerulonephritis is when you have a strep infection, strep throat, and then, like I said, the antibodies, when they hit the kidneys, they attack your freaking basement membrane. You get all kinds of nephritic things where it's allowing proteins through. It's interesting that antibiotics, you think, well, let's just jump to antibiotics, but the infection's already gone, or the strep, you've gotten rid of that. So now it's just a byproduct of these antibodies that were formed, right? Yeah. So you just got to worry about fluids and try to help them get through this time. Membranous nephropathy. That's going to be pathology of the membrane layer in the nephrons. See if you just spell it out. And what normally happens is that you've got the basement membrane here. In this case, it really thickens. Oh yeah, so that's not good at all. In adults, you'll see this problem with the basement membrane is very, very common. Yeah, and so what can cause this? You can see various drugs and infections can cause a basement membrane. I showed you that micrograph early on where the basement membrane gets thicker like this. Lupus. Lupus is an autoimmune disease. There's normal lupus and lupus nephritis. These are autoimmune diseases where you attack your own nephrons on glomerulus. All right, but let's talk to see, these are kind of cool things that affect glomerulus, but your basic high blood pressure, hypertension, what's going on? Why does that damage the kidneys so much? And I had a pathologist friend, he would come do autopsies to my cadaver lab, and he take a look at a kidney and he says, you can tell that high blood pressure looks like a granular sugar. Instead of being smooth, it has all these little bumps on it, damage from hypertension. So you wonder why it's so important with people walking around with untreated high blood pressure. We talk about stroke risk and heart attack risk, but it damages kidneys too. So that's why hypertension is something that should be screened. People without health care just slip by and you have kidney damage that could have been avoided with maybe some hypertension drugs. Anyway, so with hypertension, you damage the small arteries that get thickened. Then the glomerulus gets starved of oxygen. It starts atrophying, and the tubes all atrophy, and you get nice, healthy, plump glomeruli that have tons of blood coming to them, to these just shriveled up ones that turn into fibrous scar tissue. So hypertension can slowly cause chronic kidney disease to end-stage kidney failure. And then diabetes. I've already talked about it, but you can see your kidneys are not happy to see diabetes, because it's going to damage those blood vessels, and over time causes issues with diabetes is kidney failure. All right, so we're talking about glomerulus problems. Now, interstitial diseases, I want you guys just to recognize that. That's going to be problems not in the glomerulus, but with the tubes and the tissue surrounding the tubes. So I'm looking at it, I see all kinds of drugs that can cause this, infections, autoimmune, some radiation can cause damage to these things. So if you hear tubular interstitial nephritis, anything nephritis is just a kidney inflammation, but glomerulonephritis affects the glomerulus. Tubulointerstitial nephritis affects the tubes and interstitial. See, so the names are big, but if you know the anatomy, you figure this out pretty quickly. So this is usually caused by, an allergic reaction. So you want to watch what drug, you get a certain drug to a person, and the allergic reaction happens, and you have the tubes start freaking out, and so the cells start dying. Yeah. You may not notice it, or you could have fever and blood in the urine. Yeah, and so you'll see, urinalysis will show evidence, not the bacteria, but they'll show white blood cells, things like that. So this infection is happening up here. And eosinophils, remember those come out in parasites and allergies. And so this allergic reaction, lots of eosinophils, that's a really good clue what's going on, yeah. And so they could take a biopsy and they'll say, oh, look at that. We have tubular necrosis and interstitial problems. They have tubular interstitial nephritis. So really quickly look at what drugs are we giving them? What's causing these tubes to have an allergic reaction? So almost like all drugs can cause this depending on what a person's allergic to. So a careful drug history to see if they've had any reactions in the past. And if they take away the drug, and this can improve, the tubes can go back, then that's a real good sign that let's not give them that drug again. All right. So some various forms of glomerulonephritis or interstitial nephritis. Talked about nephrotic and nephritic syndromes having to do, both of them are damage to that delicate membrane, filtration membrane. All right, let's end up with some cancers. So urothelium, or that transitional epithelium lines the bladder, can become cancerous, of course, and 6th most common. Men get it much more likely, and especially if you smoked for a long period of time in your 70s or 80s, you'll have blood in your urine that maybe yet no other pain. They'll do a cytoscope and they'll say, oh, you've got bladder cancer. These aniline dyes have been implicated in it as well. And so you'll often see like this. You kind of have this core with blood in it, and then you have the urothelium looks unusual, and they'll do a biopsy, take a look at it and say, oh yeah, they're definitely cancers. And we'll talk about kidney cancer next. Let's take a look at bladder cancer. You can see in men much more likely than women, coming about in your older age. 80% survival by the year, they catch it, and smoking, definitely. Kidney, you can see kidney incidence here, much less than a male bladder infections. Comes a little bit earlier, a little more deadly. All right, so a lot of these are non-invasive. They just look like polyps that grow. Only when they become later stages do they invade the wall of the bladder, and they can travel to your prostate and the blood, etc. But blood in the urine, they'll do a cystoscope. They'll take a look in there, and they sometimes if they remove them, they'll come back. It's true. Yeah. But you can see staging here. If they catch it early, they can remove all of it, and you'll be in good shape. If it's scattered throughout, they may have to remove the whole bladder too, as well. Yeah, but usually just blood in the urine, painless. They can take a look at it. Yeah, and then once they remove it, they want to have you come in to check to make sure it hasn't come back, and they can even look at urine samples for abnormal cells. All right, the kidney. First, I'll talk about, here's one that's kind of congenital thing. They can even see it in utero, but a nephroblastoma will be a big tumor. Well, shows how small, but a tumor that forms in the kidneys. That's happens in children, and so they need to take care of that. So that's one that will come about. But more common than that is just renal cell carcinoma. This is kidney cancer. It's not up in the top cancers, but it certainly happens. And it's carcinoma, cancer of the kidney cells, right? So smoking, men more than women again, and as you get older, of course, much more common. Chronic kidney disease. There's some genetic components. So what are some of the signs? Flank pain, pain. Maybe they can palpate a mass, blood in the urine. Yeah, usually you don't have all three, but 2 out of 3 will make you take a look closer. And so it doesn't, chemotherapy, radiotherapy, I guess, not work as well, but if they can usually go in there and remove it, you can remove a whole kidney if you have to, right? But if you can remove the mass, that'd be great. Or embolize or cut off the arteries that are feeding it. All right, organ failure. If you have kidney failure, you can't live long. You need dialysis that will keep you alive, or a kidney transplant. And so kidney failure, acute, something that happens rapid onset, or chronic kidney failure, CKD, chronic kidney disease, happens over a long period of time. So acute tubular necrosis is that usually some kind of toxin is going to damage the kidney tubules. It's life-threatening. It needs to be dealt with immediately. So these toxins include heavy metals. If you eat the wrong kind of mushroom, you can cause acute kidney disease. Definitely. I collect mushrooms myself. I know that's an issue. Sometimes the mushroom combined with alcohol causes it. It's really interesting. Ethylene glycol, you know what that is? It's antifreeze. Yeah, don't want to drink that. Definitely. Yeah, and so you can see it's going to attack the kidney tube cells, and you can come back from it, but it's if untreated, you're on the pathway to death. So yeah, very little urine production. So hopefully they can catch it, stop the original cause of it, and put you on a path to healing this acute kidney disease. Now, chronic kidney failure, just very common in the elderly, people with chronic diseases in the hospital, kidneys. And one thing I should point out too, whenever you're thinking about dosing drugs, things like that, you need to look at kidney function. And if the kidney's function is very low, you can easily overdose a patient because they don't break down the drug as quickly. So you look at kidney function when you're giving drugs to see, can the patient handle it? Are the kidneys working well enough? Otherwise, you got to make adjustments. Yep, develop slowly. You may just come in and they look at your bloods and levels and look, hey, that's awful high bond in creatinine, and so it can happen if you're older and you come in, you have these high levels, then they want to take a look and see if you've got this chronic kidney disease. And it could be, you could die of something else. It could be very slow growing, or it could be more rapid and you're on your way to having worse and worse blood results. So azotemia, you see that's nitrogen products in your blood that should be removed, retention of fluids, and just everything the kidneys should do, electrolyte and fluid balance, they're not doing. It's a sign of the kidneys are failing. All right, I mentioned uremia in an earlier lecture when we talked about clotting, because if you have urea building up in your blood, your kidneys are supposed to get rid of it. If they don't, it's toxic. And one thing it does is it attacks, it hurts platelets, and so you have clotting issues. Your brain, it can put you into a coma. Mental status, coma, if you have high levels of urea are toxic to you. And you have all kinds of issues with your heart, your brain. And so you got to be on dialysis. So when your renal function is that bad, you're just not getting rid of that urea. Remember, your liver makes it and your kidneys get rid of it. It makes urea from nitrogen. All right, dialysis machines, pretty amazing. We don't really have a machine that can completely replace a liver, but we do that can completely replace a kidney. You don't want to be on dialysis forever. You want to fix the problem, get a new kidney, because you got to go like 3 times a week for hours hooked up to this. So you got to keep a port open so that they can hook you up to the blood thing. So it's something that will keep you alive if your kidneys have failed. And, take care of fluid issues, metabolism issues. There's a membrane in there that takes care of the blood, filters it, and it's pretty amazing engineering. So that's, we just call dialysis usually, or hemodialysis is blood dialysis, but there's an alternative, a peritoneal dialysis they can do. And with this, and you can do both of these at home, although a dialysis machine is really expensive. Usually go to a center to do this. Peritoneal dialysis, they put a saline fluid into your abdominal cavity. You do this yourself. You inject all this fluid, you wait a few hours, then you drain it. Because there's so many blood vessels there, the waste will go into that fluid and you can drain it. You gotta do that more often. It's not as good as hemodialysis. And there's always a chance of introducing bacteria in there, and so a chance of infection. Either one, but especially this one. Well, a transplant is the way to go if you want a new kidney. Well, obviously, right? How else are you gonna do it? And so this is the most common organ transplant, been done a long time. We're really good at it. If your kidney is bad, they don't even put it back where the kidney is. They just put it down into the pelvis, because why put it up there? It's gonna be too loose. Put down in the kidney, down in the pelvis, you've already got the bladder next to it. Just connect it to the bladder, connect it to any blood vessel will work. So connect it to the aorta, and the kidney will work down there. It could be in your arm, your neck, but it works well down the pelvis. And then it takes over your kidney function. As long as you don't reject the organ, right? It's not your organ. So in the future, we want to grow new kidneys from stem cells and just give yourself your own kidney. But that's not here yet. So you can get one from a donor kidney from a cadaver person that just died, or find a living donor. That's when you find out who your friends are. And when I teach evolution, we look at this too. It's just, people will give kidneys to relatives, 1, because they match, and 2, because we care more about relatives, and not because just of our evolution has taught us that if you help relatives, you're helping your own genes. So true altruism is giving to someone by hurting yourself is very rare, very rare. And so when you see it, when you help relatives, it's not truly altruistic because you're actually helping your own genes, right? To help a complete stranger, when you see about a stranger donating a kidney, it makes the news because it's so unusual. So because there's a danger, you give away a kidney and your other kidney fails, you're not going to get that one back, are you? I mean, you can try, but it's probably not going to happen, right? So there's that whole thing about, getting a kidney, and you want to get it from the closest relative. Identical twin would be perfect. And normally you get a kidney transplant, you put on immunosuppressive drugs so that your immune system doesn't attack it. Yeah. And just to get one, you have to make sure you're not like too old or have other comorbidities. You have a lot of other issues. You're not going to be they're not going to give you this rare organ, because you got other issues that are going to kill you. And so the failure, you'll see a rejection. Hyperacute means immediately is rejected. And nowadays, like I say, they do all these tests to make sure it's as compatible as possible. But an acute rejection means you reject it, within a few weeks. And you try to give steroids and suppress the immune system, but sometimes it's just rejected. And so the closest relative, the better. And then sometimes it's rejected. A chronic rejection means years later. And so this thing may last decades for you. Or in 5 years, it may all of a sudden you have rejection issues. We don't exactly know why. All right, and lastly, your book brings it up, so I'll bring it up too. This whole idea, why can't you sell a kidney if you want to? This is America, right? Why can't you do that? And if someone offered you $1 million, would you get rid of a kidney? My answer is yes, in case you're wondering. I'm cheaper than that even. But indeed, because you can live with 2 kidneys, but you're taking a risk. And the surgery is somewhat of a risk, but just the idea that with only 1 kidney, I just talked about all the diseases, right? The things that can go wrong. So you're taking a risk with just 1 kidney. It helps to have 2. But what it really sets up is this medical tourism. Yeah, you can go, I guess Iran is the only place you can legally sell them. In the United States, you cannot sell a kidney legally. Sometimes people do it. But in some countries, and I saw a special in Pakistan, I think they had these places where there's, I think it's these middlemen. They find these really poor people and they offer them just not that much money for their kidney. And then sometimes they're underage, et cetera. And these kidneys are sold to rich tourists from Europe and the United States who come there for the kidney because they can't get a kidney because there's a huge waiting list in the US, right? So this whole idea is that why we don't allow it, the ethics of it is that we don't think we should set up a system where the poor sell their organs to the rich, because that's what it really comes down to, isn't it? But on the other hand, should we be able to sell a kidney? Should we have that option? Is it, we can sell sperm, we can donate eggs, yeah, right? But we can't sell a kidney. So anyway, I thought I'd throw that out there. It's interesting to think about. From one hand, you're like, yeah, we should be able to sell kidneys. 2, it's like, oh, it's going to set it up where we have this class difference and groups of people selling it to other people. All right, well, a lot of kidney issues. Kidneys, pathophysiology, liver and kidney are things that are going to involve your metabolism, so your blood work, and then, of course, it can look right directly at your urine is a direct product of it. So you enjoyed that, and yeah, we've covered a lot of the major internal organs now.